करुणेश चेक करो
यस।
जरा यूट्यूब पे आ गया क्या विनीत भाई।
हाँ सर, आगे आगे।
ओके। ये पहला प्रयोग किया है डायरेक्ट उसमें।
कैसे?
मतलब खुद ही पढ़ पढ़ के इसकी लाइव जूम पे लिंक बनाई
यस
और
सर।
यूट्यूब पे लाइव किया है उसको।
सर, आप लोग भी सर ग्वालियर एकेडमी और पीटीटीस का यूट्यूब चैनल लाइक और सब्सक्राइब कर लीजिएगा बाद में।
डायरेक्टर साहब की जय हो।
वाह भैया, बंसल साहब बैठे सामने तो अपने आप ही सब अच्छा हो जाता है।
सर, गुड इवनिंग सर।
हाँ, गुड इवनिंग भाई।
नमस्कार सर।
नमस्कार।
गुड इवनिंग सुजीत सर। नमस्कार
हाँ जी,
सर।
वेरी गुड इवनिंग बॉस।
आफ्टर लॉन्ग
गुड
गैप
इवनिंग
आई
सुजीत सर, गुड इवनिंग सर।
हाँ, गुड इवनिंग बॉस। अभी 5 मिनट है ना?
स्थिति आ जाए तो आप युद्ध बंद कर सकते हैं। इस वाले केस में जो प्राइम मिनिस्टर ऑफिस ने सबको
Good evening, Ajit sir. Good evening.
गुड इवनिंग।
अजीत भाई नमस्ते।
नमस्कार, गुड इवनिंग बॉस, गुड इवनिंग।
Very good evening to all.
गुड इवनिंग बॉस, गुड इवनिंग।
Good evening, Rahul sir. Good evening.
गुड इवनिंग जी।
हाउ आर यू डॉक्टर सिंगारा बिल्लू सर,
Fine
कैसे हैं
sir.
सर?
Fine with all your.
मैं तुम्हारे साथ खड़ी हूँ।
Good evening, Rahul sir. Good evening.
गुड इवनिंग।
देवेंद्र सर, गुड इवनिंग सर।
Good evening, sir.
विपिन भाई आ गए उसको।
Good
सर
evening,
प्रणाम
Vipin
सर,
sir.
गुड इवनिंग
Good
सर।
evening.
विपिन भाई गुड
बंसल सर,
इवनिंग।
गुड इवनिंग बॉस, प्रणाम सर।
Good evening, sir. Vipin sir.
प्रणाम
Good
प्रणाम
evening.
सर प्रणाम।
Good evening,
Good evening,
everybody.
boss. Very good evening to all.
विपिन भाई थैंक यू सो मच। आप कंसीडर किए राहुल सबसे ज्यादा। राहुल तुम थैंक दो विपिन भाई को।
बिल्कुल। थैंक्स टू ऑल।
Thank you.
Thank you, sir. It was insistence of Dr. C.P. Bansal, then I could not say no.
Good evening, Ashok sir. Good evening,
Sir.
sir.
Ashok sir. Good evening.
Good evening.
Very good evening, sir.
गुड इवनिंग।
कैसे हैं? आज अच्छा है, कोविड के बहाने सबके दर्शन हो गए।
सही है।
Namaskar, sir.
नमस्ते जी।
ये मुझे लगता है जो कैमरा बंद आ रहा है यही धीरेन है। इसका वीडियो कुछ कनेक्ट नहीं हो पा रहा कह रहा है।
धीरेन पेशेंट देख रहा होगा, हो सकता है।
Good evening, Hema Bindu madam. Good evening.
Good evening, sir. Good evening.
गुड
Good
इवनिंग
evening,
डॉक्टर
madam.
हेमा बिंदु।
Namaskar, sir. Good
Good
evening, sir.
evening.
Namaskar, sir.
Good
Namaskar,
evening.
Dr. Hema.
नमस्ते।
To see all the stalwarts here. They're very nice, sir. Gwalior webinars. It looks like a very nice series. नाम भी बहुत अच्छा है।
Something new.
Yeah. Banga, sir. Good evening and
Good evening.
good evening, sir.
I think IAP will take over the whole digital platform. Your chapter and IAP and
Oh my God.
different new platforms.
Okay. So, namaskar, sir. Vineet Saxena, sir.
Namaskar.
Namaskar,
Good
sir.
evening.
Namaskar, Vineet ji.
Yeah. Dr. Karunesh, sir. Good evening.
Good evening,
Namaste.
ma'am.
Namaste. Namaste. Good evening. Sujit, sir. Good evening. Namaskar, sir.
Dr. Hema Bindu, namaskar. Very
Yes,
nice
sir.
to see you.
I know, sir. Same here.
महेश वेलकम।
Good evening, sir.
Good evening, Mahesh
गुड
sir.
Good evening,
Good
all.
evening, Mahesh.
Mahesh
Absolutely
ji, good
fine, sir.
evening.
How are you? Thank you,
Good
ma'am.
evening,
Good
Mahesh.
evening.
Good evening, Maheshwari.
Good evening, sir.
Mahesh, good evening.
Good evening, ma'am. Good evening. Good evening, sir. Good evening, everyone.
केतकर सर
Ketkar
पाए
sir.
लागू।
Hello. Good evening.
Good evening,
Namaste,
Ketkar
sir.
sir. Good
Sir,
evening,
Good evening,
sir.
sir.
Namaskar, sir. Nice to see you, sir.
करनेश धीरेन को एक बार फिर पूछो क्या इशू हो रहा है।
जी
आई थिंक वो यही वाला है जो बीच बीच में कैमरा बंद आ रहा है।
Hello, am I audible?
Yes,
यस
Yes,
sir.
sir.
सर।
Very much, sir.
Good evening. क्या हो गया?
हाँ आ गया धीरेन।
हाँ, Dhiren sir joined, sir.
अभी कुछ am I audible and visible?
Yes, sir.
Yes, sir, very much.
हाँ, यहाँ से मेरे यहाँ से गायब हो गया है।
हाँ धीरेन, तुम
सर गुड
फोन से
इवनिंग।
ज्वाइन किया है?
हाँ सर, वो लैपटॉप अभी एक्चुअली में आज ही नया आया है, तो कुछ सेटिंग में गड़बड़ है। अभी मैं 2 मिनट में लैपटॉप से आ जाऊंगा।
डॉक्टर महेश महेश्वरी, गुड इवनिंग।
Good evening, Dhiren sir. Good evening, sir.
सर गुड इवनिंग।
Good evening, everyone. Good evening, Dhiren sir. Good evening, Ketkar sir. Seeing you after a
नमस्कार।
long time.
बहुत दिनों बाद मुलाकात।
बहुत दिनों बाद दिखाई रहे धीरेन सर आप।
गुड इवनिंग केतकर सर, गुड इवनिंग।
गुड इवनिंग सर।
Sir, good evening.
धीरेन सर, गुड इवनिंग।
नमस्कार।
धीरेन जी की टाई चमक रही है।
सुजीत आजकल कहाँ हैं?
कौन, मैं?
हाँ,
मैं सर कहीं भी नहीं हूँ सर,
आई
वैसे ही
थिंक
सब जगह हूँ बस।
अपन शुरू करें। तीनों पैनलिस्ट अपने हैं एंड वी आर ऑलरेडी 5 मिनट्स लेट।
ओके।
बांगा सर,
हाँ बिल्कुल।
केतकर सर,
यस, ओके।
और एमपी आईपी प्रेसिडेंट ऑलरेडी आ गए, तो आई थिंक वी शुड स्टार्ट। महेश शुरू कर दें?
हाँ, विपिन भी आ गए।
जी
हाँ
सर, बिल्कुल
नमस्ते विपिन
बिल्कुल
जी।
सर।
नमस्कार बांगा से।
नमस्कार विपिन जी।
विपिन जी
मैं
नमस्कार।
सर बीच में हो सकता है ये स्विच ऑन कर जाऊं लैपटॉप पे, तो 1 मिनट हो सकता है मैं बीच में गायब हो जाऊं,
हाँ हाँ, नो इश्यूज।
क्योंकि इसको पकड़ के रखना पड़ेगा।
स्टैंड पे लगा दो।
बस सर 1 मिनट को अपडेट ले रहा है।
कोई प्रॉब्लम।
स्टार्ट कर सकते हैं सर। सर गुड
धीरेन की
इवनिंग
तो
एवरीवन। राहुल
धीरेन
सर,
की टाई तो
केतकर
बहुत
सर,
शानदार लग रही
सुजीत
है।
सर।
धीरेन लुकिंग डैशिंग।
अरे सर
एक टाई वाला तो है अपने पास।
Good evening, everyone.
वेरी गुड इवनिंग।
Good
On
evening,
behalf of Gwalior Academy of Pediatrics, I welcome you all. The Gwalior Academy of Pediatrics proudly presents its inaugural and continuous webinar series dedicated to exploring general topics in day-to-day clinical practice and understanding the clinical scenario and evolving pattern of diseases. As we embark on this new knowledge-sharing journey, we aim to foster insightful discussion with renowned clinicians and experts, bringing evidence-based update to pediatric care. The visionaries behind this series, the Gwalior webinar series, it is the brainchild Dr. C.P. Bansal sir, Dr. Anand Ketkar sir, Dr. Banga sir, Dr. Ajay Gaur sir, and Dr. Suhas Dagli sir. They are stalwarts in the field of pediatrics, whose passion for education and advocacy has led to this continuous learning initiative. Their vision is to create a knowledge-sharing platform that keeps clinicians updated on the dynamic landscape of pediatric healthcare. And we learn from our renowned experts and discussing emerging trends and real-world cases and enhance decision-making in routine critical scenarios. In our series of webinar, the first episode, the COVID-25, or rather we say COVID returns with experts' prediction. At present, India reports about over 1,000 cases of active cases, with maximum spikes in Kerala, Maharashtra, Delhi. Now new cases have emerged also in Punjab and Gujarat also. So every hour new cases are being diagnosed, and it is creating a little panic in general public and others. So in this our series, we'll continue driven. We are privileged to have 3 distinguished experts, each bringing their own depth of experience and expertise. Our speaker, Dr. Sujit Singh sir is former director of NCDC. He played a pivotal role in epidemiological investigations and pandemic preparedness. He was part of expert groups shaping India's response to future pandemics, emphasizing data management, surveillance, and early warning systems. A highly respected clinician known for his exceptional contribution in infectious disease management. His commitment to improving pediatric healthcare is evident in his insightful clinical research and patient-centered approach. The second speaker, Dr. Vipin Vashishta, is a leading infectious disease and vaccination expert. He contributed extensively to COVID-19 vaccine research. His book, COVID-19 Vaccines, a comprehensive overview, provided critical insights into vaccine efficacy, booster doses, and immunization strategies. A leading expert in pediatric critical care with a keen focus on respiratory illness. His evidence-based approach has been instrumental in shaping COVID-19 management strategies for children. The speaker, Dr. Dhiren Gupta sir, he is a pediatric intensivist at Sir Gangaram Hospital. He was actively involved in critical care management during the pandemic. He highlighted the importance of genome sequence in identifying Omicron and Delta variants, stressing the need for accurate diagnostics. A distinguished healthcare professional whose expertise in epidemiology and disease patterns offers critical perspectives on emerging infections, making him a trusted voice in medical discussions. Joining us in this exciting academic endeavor, where we engage in meaningful discussion, share clinical insights, and collectively enhance pediatric healthcare for the betterment of our children.
Okay.
With that, I would like to invite Dr. C.P. Bansal sir to take it from a lead to the discussion forward. For viewers, you are welcome to post your questions in the chat box during the sessions, and we'll address them during the question and answer segments. Over to Sir Dr. Bansal sir.
Thanks, dear Karnesh. My very sincere respect and regards to all esteemed stalwarts of Indian Academy of Pediatrics, especially out of Gwalior. And I am really grateful to Dr. Neelam Mohan Madam for joining today, Dr. Singara Velu, Dr. Hima Bindu, and at a very short notice, Dr. Mahesh has joined, State IIP President, and our own Dr. Suhas Donde, Dr. Banga sir, Dr. Ketkar sir. I am also grateful to my esteemed panelists for being with us and all the listeners today. Good evening, everyone. So we are here today at a crucial time, reflecting on the lessons of the past and preparing for what lies ahead. While the latest COVID-19 strain, often referred to as COVID-25 by media, has not affected children so far. We do not have any pediatric case so far, and fatalities also which have been there are mostly with almost all 7 have been with comorbidities. But it remains vital to understand what our experts today expect from this new phase. The emergence of variants like JN1, LF7 and NB1.5 has raised important questions. How strong are these new strains? Should we really be concerned? While experts reassure us that these variants are more transmissible but not necessarily more severe, it is essential to stay informed and prepared. Tonight we are really privileged to hear from 3 leading experts in Indian medicine, individuals whose guidance was invaluable during the peak of the pandemic and whose insights will help us to navigate the future. Their perspectives will shape our understanding on the evolving situation and guide us in making informed decisions. Let us listen, learn, and discuss what they have to say today. Dr. Sujit Singh, we all know, is a director NCDC. Dr. Vipin Vasist, a renowned vaccinologist of international repute. Dr. Dhiren Gupta, Director Pediatric Critical Care at Gangaram Hospital, New Delhi, a frontline hero who navigated the complexities of COVID-19 in children. I'm sure that each one of us, and more specifically many of us like Vineet Bhai, Dr. Vipin, they all will witness that they have contacted one or all three of them somewhere in during the phase of acute COVID. So let us see and hear from them what they think of the past ahead. The floor is open for a candid and crucial discussion. My first question on current state and surveillance focus to Dr. Sujit Singh. Dear Sujit, based on your experience at NCDC, what are the most important signs which we should watch to understand how COVID-19 is spreading in India? As said by Karnesh, we are over 1,000 active cases and new variants like NB 1.81 and an LF7 have appeared. How dangerous are these compared to the older variants? Should we be really worried or they pose a lower threat? Over to you, Sujit.
Thank you, Dr. CP, and very good evening to all the stalwarts of IAP. I am really privileged to be in this particular webinar series, the first of its kind, and it is really good on the part of Gwalior IAP to host this particular important discussion at this crucial juncture. Every day, day in and day out, we are getting calls not only from media, but also from various faculty members who have been ex-colleagues of ours to just give advice with regard to what we think, because this has been a very, very complex pandemic, as we all have seen, and at one point or the other, every one of us have been proved wrong. So it will not be right on my part to say that all that we are going to speak or we are going to presume is going to be true. But having said that, the experience of 4 years, which has been with us throughout, has given us a lot of insight, lot of wisdom, lot of intelligence that how we should be looking at the scenarios and how we should be using this particular scenario and our past experience to help us rather drive into the future. So the critical signals what Dr. CP was referring to, I like to classify them into three aspects. Number one, global scenario. We should be keeping a close eye what is happening globally. And in this particular scenario, three things are important. What is happening in our country, what is happening in the region, and what is happening globally. Globally, WHO is estimating around 15 countries are experiencing more than 10% rise in the cases. Overall, there has been decline, but testing, if you look at the testing numbers, they are less than 50,000 in the whole world. So it is very, very low. At one point of time, we were testing nearly 10 lakh, more than 10 lakh per day. So looking at that, if you are having very less number testing, the positivity does not have that much meaning. But then comes the scenario which is happening around us. Singapore, cases have doubled, 30-fold rise in 10 weeks. Then we are having positivity in Hong Kong, positivity in China, rising from 7.2 to 16.8. Positivity in Singapore, again doubling in 4 weeks. With even the severity in cases, 81 severe cases, 30 of them have died. But the point is, those who have died are really having the comorbid underlying conditions. China, we don't know the real picture, but yes, definitely hospitalization day by day is doubling. So that itself is a good enough warning to all of us. First is this. Then there comes to variants. Which variants are playing role? In many countries, like why we are not seeing similar scenario in Europe, America, and other countries? Because there the dominant variant is JN1, JN.1, which is the variant which is the Omicron sublineage, and which has been primarily causing us the concern, which or the complacent scenario which we have seen after Delta wave. Omicron, which has got more than 30 mutations in the spike protein region, 50 mutations overall, that has changed the virus character from highly infectious or the high mortality to low mortality with high transmission, which has given us a rather a comfortable scenario, which we are experiencing for past maybe now more than 2.5 or 3 years. So that has been the case which is there. But severity in some countries is a thing which has to be watched. The variants which we are experiencing in India and around us are the two variants which CP has already referred, that is LF.7 and NB.1.8.1. So these are the sublineages which are of a variants of JN.1 only, because this is RNA virus. 7 to 8% mutations are very common in every stage, and this particular dot refers that they have given offsprings. इनके एक तरीके से हम कह सकते हैं कि इनके बच्चे हुए हैं, तो इस तरीके से ये एक दूसरे को रिप्लेस करते जाते हैं। JN.1 जो डोमिनेंट वेरिएंट था, अब हमारे यहाँ 50% तक पहुंच गया है. इट इज गोइंग टू रिड्यूस फर्दर, एंड दीज टू अदर वेरिएंट्स व्हिच आर स्ट्रॉन्गर वेरिएंट्स of JN.1 like LF.7 and NB.1.18 are the stronger, and they are going to take over. They are the variants which are playing rather a more complex scenario in Singapore, Hong Kong, China, Thailand, which are around us. So we should be watchful about the severity. Second important aspect about from the global perspective, I'll come to the genomic surveillance. The genomic surveillance which the country is currently undertaking is some branches of INSACOG labs are still working, like ICMR and others. They have already found these variants which are working in our country. So, but point here is that finding variant is not important. How that variant is having public health impact means whether it is increasing transmission in a particular community, whether increasing hospitalization in that community, whether it is causing increased mortality or testing evasion. So these are the public health impacts about which we should be worried. That is why genomic surveillance has to be complemented with public health surveillance. If you don't complement these two, finding one or two cases of JN.1 or LF.7 or this does not have any meaning. So you have to complement that and see that how that impacts it. And for that, we have two important aspects. Number one is INSACOG, number two is IHIP or the IDSP surveillance. So these two are important. Now coming to the third important aspect, which is the hospitalization or trend which is happening in the community. Because hospitalization comes little later. First, you will have increased transmission, then you will have increased hospitalization. This will go into more severe cases, and finally, you will have the mortality. If you are not having severe cases, that does not indicate that the variant is not going to have severe cases in future. Maybe our testing facilities are not working to that level at which they should be working. Similarly, the genomic surveillance is not being complemented by the public health surveillance to see the correct picture. So if you do not assess the correct picture, then definitely we will be in a dark. Third important aspect which I would like to refer is the wastewater surveillance. This is a very, very important indicator as of now. And all these countries which I have referred are having very, very serious scenario as far as wastewater surveillance is concerned. What is wastewater surveillance? It gives us 2 weeks prior to the transmission which is going to rise in the community. If you find high viral load in wastewater, 2 weeks later, you will find the same viral load in the community which is giving that wastewater. So that is a rather pre-indicator, you can say, of a higher increased transmission which is going to happen, and that is what which we are seeing in our country. Our country, we formed up this wastewater surveillance network, but till as of now, I think it is not being complemented by other scenarios. So we may not be having that confirmed information with regard to that. So I'll stop here as of now, and I'd like to have insight from other experts, and then we can go further.
So you have not answered that. Should we really be worried, or we should Delhi abhi dur hai?
No, you have worry is not the right word. We should be concerned. But yes, more importantly, doctor community or the medical fraternity should be concerned. We should be watchful about the ARI cases, ILI cases, or the cases which are coming to us in form of comorbidities, having respiratory symptoms. We are all aware about the various diverse symptoms which we have experienced, like even the smell goes on, taste goes. So all these symptoms we know fully well, and we should be watchful of them. And as soon as we find the case, we should be trying to refer those cases for RT-PCR. And if at all we find RT-PCR positive, which which a viral load of more than CT value of more than say around 30 or so, then we should definitely subject him to the genomic sequencing also. So to find out that which particular variant. So this is very, very critical chain about which we should be very, very concerned, and we should be very careful about it. This is our
So
duty. We
monitoring should be very strong and robust right now.
yes.
Over to Banga sir. Unmute yourself. Banga sir, unmute yourself.
Yes, Sujit ji, thank you. You have given the basic information about the situation. But what will be the early warning indicators for any significant resurgence? How we doctors community must pick up the signals of coming COVID beyond genomic surveillance, means that at your level it is being done. What are the key epidemiological parameters such as test positivity rate, hospitalization, as you said, wastewater surveillance, and which one or two or all these are the parameters that indicate that COVID is coming? And
No,
what how do you explain to the public about the variant of interest, variant of concern, and all these technical terms?
Okay, thank you, Banga sir, for your question. So I think this is very, very important, that how to interpret the positivity, how to interpret the genomic variant, and how to interpret the increased hospitalization trend. I think all of them have to complement each other. Testing alone or the test positivity alone will not give you the correct picture. How many samples you have tested, where you have tested, because once you find the hospitalized, that's what I was trying to explain the previous question. Once you find, because now we have to wait for the signals which are coming to us. If we have increased hospitalization due to ILI cases or the respiratory cases, we should immediately look for a sample of them to subject to RT-PCR. Then out of those samples which we find positive, we should subject them to the genome sequencing. And once we find out the variant, we should go back that from which particular community or which particular area of our city that particular variant was detected. Once that is detected, you should correlate it with whether that particular area is having increased transmission or not, whether that particular area is giving more number of cases into the hospitals or including the clinics or including our system or not. So if we look at these indicators, we will definitely be able to give vital information to the national network that this particular variant or this particular hospitalization is due to a particular variant. That is one. Second, as in the initial remarks, they have mentioned that 1,000 cases. Now coming down, we have to drill down these 1,000. From where these 1,000 are coming? 430 are coming from Kerala. 153 are coming from Maharashtra. So 76 are coming from Gujarat. You have to go down again deep. 76 from which area of Gujarat? 153 from which area of Maharashtra? We know that these all three states are having higher number of testing inclination. We have seen in H1N1, we have seen in SARS, and all these things. They have the labs which are doing this. So we have to look at the denominator, what is the denominator, and what is the positivity. So if we look at these things and use your epidemiological intelligence, then definitely we will be able to find out that whether we are going to face some challenging scenario or not. And that is what which is required, the eternal vigilance, or we have to be vigilant about the scenario which we are facing.
Yes.
And one more thing, so sorry, sir. Sorry to intervene, because I just wanted to highlight that we are right now having the population which is heterogeneous. By heterogeneous, what I mean, when the COVID came, we were all susceptible to equal level. I'm not talking about the host immunity status or the personal immunity, but as far as the susceptibility to the new virus was considered, we were all in the same boat. Now, in this particular scenario, some of us have been vaccinated by Covaxin, some of us have been vaccinated by Covishield, others have got exposed to Delta, others have exposed to Omicron, someone have to earlier variant. So we have a heterogeneous population. We never know that what type of immunity we are having, whether the immunity has went off totally, whether we are having. So all these population will, our new variants will behave differently in different countries. And that is what which is happening across the globe also. Numerous variants are playing role, and we have to see that which variant in our country becomes a variant of concern and gives us the scenario which for which we should be more careful, more better prepared. Thank you.
Yes. Thank you.
Dr. Banga, can I come in?
Yes, please.
One quick comment here. I think Dr. Bansal asked whether should we be worried about this current outbreak. If you see the situation right now, for last 2-3 years, we are having annual outbreak. Last year, we had February to April GN1 outbreak in India. In 2023, we have XBB 1.6, that is Arcturus. So we are having regular outbreaks of these. And you see the global scenario. US, they are calling it is a lull now. Wastewater is very low. Emergency department visits, hospitalization, deaths are very low. Still, they are having 175,000 new cases every day. You can think of it. And 1 in 190 people is infected with the COVID right now. You see the situation in India. We are under testing, as Dr. Sujit has said, but still, if you go, the real number may be much higher. But it is the previous wave which have vaccinated most of us. I'm not talking of vaccines, but the natural infection which provide you better immunity against different types of SARS-2 components, which is more potent, and that will provide us protection, because you see that these two variants, they are descendant of this JN1, and we had a significant wave in last year also. So we may be having some sort of a population immunity, but especially those kids who have born after say April and May, they may not be having any amount of immunity either from the vaccine or from the uh, natural immunity. If you see the current scenario, there's nowhere in the world it is causing a severe disease. Especially in Hong Kong, the pediatric wards are full, but still majority of them, they are having high-grade fever, vomiting, and other respiratory symptoms, but still no deaths as far as pediatric population is concerned is seen. So in my opinion, I think we should not be extremely worried about it, and I think it is a matter of 6 to 8 weeks, and this wave will wipe out. And globally, in Europe and US, they are having XFG now, which is more advanced if you compare with LF7, one grade beyond that. And the people expect that by the July, the Europe and US will have this XFG, and the Asian countries will be having this NB181 and LF7. So the situation will evolve, but still, I don't think that it will cause any mayhem what we had during the earlier waves also. Thank you.
Oh, thank you. I think next question is for Dr. Anand Ketkar.
Sir, considering previous waves, what protective measures for public point of view policy are prioritizing in prevention of potential hazards of COVID-25? That what experiences, what we had from past experiences of various waves which we have faced of COVID. Dr. Sujit, please.
Thank you, sir. And just to add to what the Vashit sir has already mentioned, yes, definitely there is no reason that why we should be worried about Omicron, its sublineages or recombinant, which are right now playing everywhere. So that may not be giving us that particular scenario. But my point basically was to be careful, to be watchful about the hospitalization, and see to it that how the scenario evolves. Having said that, regarding preparations, I think there is a need that we have gone into a complacent phase. We are right now, I was just looking at the ICMR data, which I got just now. From 73 Sentinel sites, they are collecting around 12,000 samples per week. So that is the way in which we are doing testing. We are only focusing on the Sentinel sites. That is primarily the sites where high positivity, high hospitalization of the ILI cases are taking place. We are not primarily focusing on the overall country as such. So we are testing as a sentinel surveillance, which is the strategy also right now. Whenever you don't have, we divide the country or we divide the areas into 3 categories. Number 1, affected category. Number 2, non-affected. Number 3, at-risk category. So for all these, the surveillance strategies are different. But yes, I will like to put it like this. We have to have a convergence between the laboratory data, between the community data, and the data which is there under this hospitalization. So if we complement all these things, we will definitely have a more clear picture. And as soon as the picture evolves, we can be better prepared for future.
Can we go for
Thank you.
RT-PCR to suspected patients for getting this COVID?
No, I will not advise that for each and every patient you should go for this particular, where you have high degree of suspicion, and particularly where you are anticipating that there could be some underlying. We know all the tests also. You can go for the CT scan also, or another other that mnemonic patch or something like that. If at all you find that particular picture, in those cases, I think there could be that you can go for the RT-PCR testing. And the numbers which currently we are seeing the increase, right from 257 to over 1000. This is just because the testing has increased. People have become a little bit more vigilant as far as the testing is concerned. I will not call it as a real that in 2 days we have gone from 257 to 1000 plus cases. So I will not call it as a real picture. So that picture really has to be correlated with the denominator what I was talking about. Kerala testing more, we are getting more positive cases. Other places, Delhi, we have started testing today, day before yesterday only. So we got around 100 cases. So I don't think that this is going to be rather, because the milder COVID you will always find. And many, if you are testing more numbers, you will definitely, and Omicron to me does not seem to be a area of considered. It may give you the positivity, but unless the disease is severe or you are anticipating that the prognosis is progressing in another direction, then only I think you should go for this. But yes, my one caution would be that if you are examining a case, then better would be to take precaution for yourself. Thank you.
Okay, thank you. Thank you so much.
Thank you, Sujit, and thank you, Vipin bhai. I think the consensus is building up that definitely the threat is lower, but we should really be concerned. Now we move on to round two of vaccines and immunity. And my question you all will understand to our vaccinologist, our pride of Indian Academy of Pediatrics and Vaccines, none other than Dr. Vipin Vasist. Dear Dr. Vipin, new COVID-19 variants keep appearing, as you rightly said, 2 years before there was one, then again. My question to you is that how do our current vaccines protect us for these new strains? Can they still prevent the infection, or more importantly, do they really help us in becoming the infection more serious or increasing the rate of hospitalization?
I think if you see the current scenario, if it depends upon the objective. What is your objective? If your objective is prevention of hospitalization, severe disease, and deaths, then probably your natural infections or vaccination. Three, you need to have three exposures, and that will protect you against these severe disease, hospitalization, and death, because it stacks up your T cell compartment, the cellular compartment, and it is the T cell immunity which is providing you the protection against the severe disease, hospitalization, and death. If your target the prevention of infection or mild disease, no vaccine. I'm going to tell you no vaccine, whether it is JN1 adapted, the Moderna, Pfizer, or Novavax variant, which is a booster vaccine, which is available globally. It is not going to be provide you much protection, except for hospitalization and admissions. And the current data, if you see, there's the newer vaccines which are JN1 adapted, and against these two variants which are coming up right now, there was double fold reduction in neutralization. So even they are not able to provide you protection against these new variants as far as the mild disease is concerned. If you had COVID vaccine, whether Covishield or Covaxin, earlier also, and you had two more instances, total combining three exposures to vaccines or natural infection, it means you are protected against these severe disease, hospitalization, and death. For how long? It may be about decades or more, because we have seen in SARS-1 that those who had infection earlier, up to 17 years, the T cells were holding on against these SARS-1. It was seen in the earlier studies also. So my point of view, if our objective is against protection against severe disease, hospitalization, against these variants, the our older vaccination as well as natural immunity, natural infection, which is sufficient. But if you are changing prevention of mild disease or infections, no vaccine in the world currently available to stop that. And frankly speaking, if you see of the current vaccine scenario in India, there hardly any COVID vaccine which is available. And the most advanced one would be the Jamcovec OM type, which is Omicron adapted one booster, but it is right now not available. Or again, it is based on BA1, which is maybe it may not be effective against these current variants. So, seeing the current scenario, I think the one particular population that is infection and vaccine naive would be those children who were born after April, May 2024 to now. But again, fortunately, COVID is very less severe in pediatric population owing to certain immunological factors. So we need not to worry about that. Those who are most vulnerable are those people who are elderly with comorbid conditions. They need protection. But we don't have any currently available vaccine to prevent that.
Vipin bhai, can this new strains evade the vaccine-induced immunity?
No, I see there are two compartments. One is neutralizing antibodies, another is your cellular immunity. Neutralizing antibodies, which prevents you infection and transmission, they can be evaded. You cannot have a perfect a form of vaccine which can prevent that. But for your longer immunity against these severe type of illnesses, COVID illnesses, whether you are using these any type of these earlier vaccines, they are still effective, and they will provide you protection maybe up to a decade against these variants.
Sir, any boosters are
Okay,
needed?
great.
Harish Pemde.
Booster
Vaccine
for
booster at this juncture of point, at this point of time.
I think those who are elderly with comorbid conditions and having multiple immunocompromised status, definitely they should have. But if you see the situation in India, we don't have any vaccine which can provide that protection against mild disease. As I said earlier, I think these vaccines should hold good against the severe disease, death, and hospitalization. But as I said earlier, I think for decades they can provide you protection against severe disease, whether you had taken any type of vaccine. So boosters may be needed if you have availability of these newer JN1 adapted vaccines. Then they can be helpful, especially for the comorbid and immunocompromised population. You see now the current FDA has recommended that no COVID vaccine should be given to children below about 6 months till 64 years of age without any immunocompromise or comorbid conditions. They have said no. The latest FDA recommendation is no COVID vaccine should be given from 6 months to 64 years. Those who are immunocompetent and not having comorbid conditions. So you see the picture of a vaccine is quite gloomy as far as the whole scenario is concerned, considering what is the Trump administration and RFK Jr. is doing in US. And in fact, the Moderna has stopped developing their bivalent influenza and COVID vaccine combination vaccine also. They have dropped that project. So if you are having comorbid conditions, elderly and severe incapacitating illness, you need
That
some
is
amount of
great.
protection.
That is
But
really great. So no need to vaccinate right now. Just keep a eye.
Dr.
Over to
Vipin,
Banga
No,
sir.
may I
Doctor,
ask a question, Dr. Vipin?
yeah, Dr. Vashishta, Dr. Neelam on this side.
yeah,
Now,
ma'am.
Covaxin theoretically had a different way of production. So, what are your thoughts about, obviously, if we do not have the JN1 adapted, as you said, but what about
Covaxin efficacy in this, has it been studied for the newer variants? That
No, no.
so you knowing the structure, what are your thoughts on it? Because you know the structure. So what would you say? Because I remember when the Omicron variant came, we said that Covaxin would be protective, didn't we?
Yeah, I think if your objective is to prevent severe disease and death, then your T cells are holding
No,
on.
no,
Even
no.
if
That
you have
I understood. That's
you have
not the
taken,
question. My question is that in elderly with comorbidity, where high risk people, where in those, if I have to give a booster dose, what is it in your hand presently?
I think if right now there's hardly any vaccine available, even if you give us, suppose you are suspecting that the patient may have lost T cells also, that particular person. So it's a good idea to give whatever is available because it will stack up your T cell compartment. But not if your objective is to prevent mild illness or even symptomatic illness. I think they will be ineffective, useless unless
Dr.
you have
Vipin,
a specific vaccine for that.
Dr. Vipin, I think Corbevax is still available with the company. I am in
Rahul,
touch with them.
Rahul,
Yes,
with
sir.
due apologies and folded hands, may I request all the esteemed members to keep their individual questions for the end because we have couple of questions already left. So please note down your questions. Dr. Karunesh is very sincerely noting all the questions and he will put them at the end. My sincere request, please.
Vipin bhai, you have already answered a lot of the concerns that I had. But only thing I wanted to ask is that our population of 148 crores has variation, a spectrum of antibodies. We can say someone has received 2 doses, someone has received booster, someone has good immunity, some must be having a waning of immunity. So, what do you foresee the government may decide about the vaccination if COVID comes up in large numbers and we have to go for that? Then, do you think that some newer vaccine will be required, or the old vaccine, as you said, will boost up the immunity?
I
What
think
scenario do you foresee?
I think what the least the government of India will do that those specific group of individual, those who are having comorbidities, having immunocompromised status, they can have if they have already had last vaccine shot 6 months back. You can give them one booster, but objective would be to stack up your protection against the severe disease. I'm not very sure whether it will be effective against these newer variants as far as the mild or symptomatic illness is concerned. So another issue is the long COVID. I think we are not thinking we are not giving enough attention to long COVID. Each infection, whether it is mild, symptomatic, or severe, will lead to the complications of long COVID. And the whole Western world, Europe and the US, and the huge amount of long COVID patients are there. Unfortunately, we are not having good studies from India, and I'm not aware of any study done recently on long COVID, and each infection gives virus the chance to evolve further and may cause the persistence and cause immune dysregulation that may result in long COVID. Personally, I had this instance. The last year I had in February this JN1 infection, and which led to this one instance of this long COVID in the form of psoriasis and other immunological problems. So we are not giving much importance to long COVID, which is a neglected one.
आप क्या मोबाइल पे रहने वाले हो? जी सर.
Dr. Vasesh,
Yes.
most of the questions you have answered, but my concern is what immunity we had because of either natural immunity, because of post-infective immunity, or due to vaccination. Now, since there are new variants, they are coming out, जैसे इसके बच्चे बनते जा रहे हैं, and we do not know how much we are preventing their spread in our body. Secondly, how to estimate these risks in the population at large, and what type of severity should we expect in coming few days, and the severity or infectivity resistance by the vaccination with these variants which are maybe resistant. As you know, we have experienced in malaria, still we could not have the vaccine which is perfect 100% efficacy. So what is your point of view on this?
I think as far as severity is concerned, I've gone through the various preprints, and none of them, the global expert has said that they are going to cause much more severe illness than the existing or the previous Omicron subvariant. We should be rest assured that these current variants are not going to lead a severe illness or an uptick in hospitalization and death. We need to be careful, as Dr. Sujit has already said. In Hong Kong, there is a number of pediatric cases but in the hospital, but majority of them were discharged. There was hardly any mortality, some mortality around 30-40 and elderly with comorbid conditions. So we should rest assured that they are not going to cause severe illnesses. As far as the population immunity is concerned, I think immunity gained through the natural infection is much more broad, and it affects different parts of the viruses also. It is not confined to the spike protein only, where the most of the vaccines you have, they are based on spike protein, and they will have antibodies against spike only. But if you get the natural infection, the different parts of like membrane envelope and nucleocapsid, you will have all these immunity. I think the best would be, rather than changing these uh, new variants with the rapid changes in the adapted vaccines, I think we should aim to develop a pan coronavirus or universal COVID vaccines, where taking the help of these conserved regions of the virus, for example, NSP groups, NSP 5, 6, 7, 8, 9, and 12, 13, and there are different UTR regions or spike 2 type of regions, which are conserved throughout these different variants. And we can develop this, not only against this SARS-CoV-2, but in future SARS-19, or you can say other one which may come later on, different types of SARS viruses and other type of coronaviruses. That would be the best answer, I think. And we should change for look for that.
The
And
second
it is,
question is,
yeah,
sorry,
yeah,
second
yeah.
That's really fantastic piece of information, Vipin bhai. Thank you so much. But couple of times our panelists are saying that rest assured nothing is going to happen. At other time they are saying this with a warning sign. So we are little confused. Let us now invite our critical care expert of Prime Institute, Sir Gangaram Hospital, and that too the critical care unit director of pediatrics, Dr. Dhiren Gupta. He has been on a front line not only in pediatric COVID, but also many of us have consulted him. Dhiren, how do you anticipate the problem? Do this new strain will cause threat to pediatrics? As in Hong Kong, there had been lot of admissions, but none became serious. Do you expect that मिस्सी और वो सब जो खतरनाक चीजें उस वक्त होती थी, रेस्पिरेटरी डिस्ट्रेस, वो सब आएगा या कुछ नहीं होगा, बस
Thank you.
शांति से बैठना है? What do you see?
Thank you, Bansal sir, for nice introduction. I don't know whether I deserve or not, but most of the question has been answered by our esteemed previous speakers. One is that I've seen till now 5 cases of COVID in past 1 week. Four were adults and one pediatric patient is admitted with us. And what I did, I gathered information based on the available sources on the net and my friends in Hong Kong and Bangkok. So they say that till now, pediatric patient, even they did not find increase in admission rates. The one patient which is admitted with us is like a poor oral intake and some vomiting. What I have found that, as Dr. Vashish said, that each and every community is going to behave differently with different viruses. We have got NB.1.8.1 and LF.7. Sort of these are the viruses. Substrain of JN.1 is circulating, and likely these are the sub-variants which are going to affect our community, especially in the north, right? Even if we assume that, what is the difference? It has been noted that this time smell problem, that loss of smell problem is unlikely. More low grade fever is likely. Fever is not going to be high grade, and other symptoms like muscle ache and nasal congestion. So basically, if you understand, since 2022, it is always like a share aaya, share aaya, share aaya. This Omicron comes for the media, and one or two, Zoom meeting happens and nothing happens. But I agree with the previous speaker that we have to be vigilant. Till now, need not to worry. Even it comes, it is going to behave like a simple viral infection, which is going to affect upper respiratory tract infection. Except in few instances, it has been seen that 20% gastrointestinal symptoms are there. So one is vigilance against the immunocompromised, especially poorly controlled comorbidity, like patient having interstitial lung disease or severely immunocompromised patients. There might be some concern, but we have seen influenza B season. What worse can be that, right? So in general, I feel that spreadability or infection rate is going to be very high. It is going to spread because we live in masses, and there's a lot of population dense area we live. So what I assume that it's going to spread. We have seen that in past, whether it's a winter, whether it's a summer, somehow it did not affect the droplet infection rate, right? So likely it is going to spread. It is not going to spare us, and very likely past 2 years it must be spreading because it was diagnosed in Luxembourg in I think 2 3 years back, and it must be spreading. And we are not doing that sampling that will give us a fair idea, but in general, I feel that it is going to be mild, except in less than 1 year, where it can lead to upper airway nasal obstruction and croup-like situation, which I have seen in Omicron. But Omicron, good point is that MIC and other pneumonia part is lacking. We are witnessing for past 3 years. I think same is going to be repeated this time also.
Dhiren, thank you so much. Are there any set of guidelines for pediatricians or general practitioners sort of for alert that we should look for these symptoms and then we should suspect and then what to do? Or just believe that nothing is going to happen, as you said, little muscle ache and so forth.
Yeah.
So, are there any set of specific things by which we should suspect? And if we suspect, then what to do and how to manage?
Yeah. Fortunately, sir, this time I'm talking about May. Not many viruses are in circulation except in the past 3 months where influenza was the main culprit. So any patient means practically, if I recollect my 1 month knowledge, I found that lot of patients coming with sore throat, and it is said that sore throat is a major symptom this time, right? With very mild fever. So this is going to give us an idea. If sore throat with body ache is patient is coming, then likely the patient is suffering from COVID other
अरे ये
than
तो
nasal
सबको हो रहा
congestion.
है
So as I
ये तो
told you, so yes, since yesterday onward, I asked them that if it is possible, get a kit of rapid antigen, get a kit, and you can get it done. And especially where there are elderlies are there, I'm asking to get it done. Otherwise, till now, till day before yesterday, I was not thinking that okay, I'm going to test it. Probably presently it looks like major, media hype and something like that, rather than actually things of concern. But I totally agree with the previous speaker that vigilance has to be there. We don't know when it changes the colors, right? We know that every community is different, and the main worry is of Delta strain, and we know that what happened. It led to pneumonia. Otherwise, it's fine. I mean to say, less than 1 year, we have seen upper airway obstruction, and more than 80 to 90 years, especially with immunocompromised conditions, it can produce some, side effects, some morbidity. And in fact, there's a friend in Hong Kong. He also said he's a pediatrician. He says that not major problem regarding pediatric patient, but I think when we talk about COVID, we are more worried about ourselves rather than our pediatric patient. Leave aside MISC, since Delta strain, it never came, it never struck us. So Omicron less likely is going to cause MISC type of situation.
I think, Dr. Bansal, I think this variant, the current one, two important clinical features are, one is the low, as Dr. Dhirendra said, that low grade continuous fever. It is not the case with previous one. And another thing is a high amount of GI symptoms. Two important signs or clinical features
Yeah.
along with these two.
So 20 to
variants.
30% patients are presenting with GI features as based on the media reports. I haven't seen, though this time in thanks to previous government, we had lot of loose motions in New Delhi or Delhi also, which I have never witnessed. But we normally get in biofire of stool, and we found that it was mainly shigellosis, not any other viruses. Those patients who are admitted with us, we normally get biofire of the stool also. Mostly it was shigellosis, rotaviruses, or cholera.
Dhirenji, since you are the director of ICU and you have the experience of managing the last time that when we had COVID, आपके यहाँ एक वॉल रूम था. मुझे याद है कि वहाँ से सारे कॉल अटेंड किए जाते थे. सारे हॉस्पिटल्स ने ऑक्सीजन प्लांट्स लगाए थे. Are you again going to prepare your facilities for all these things? हो सकता है ऑक्सीजन प्लांट वो काम ही ना कर रहा हो, कई जगह नहीं कर रहा होगा. कितने बेड्स उसके लिए आपको एलोकेट करना है, कितने ड्रग्स मैनेज करना है, एम्बुलेंस करना है, और क्या क्या चीजें. तो अगर आपको लगता है कि ये इस टाइम कोविड इतना सीवियर नहीं होने वाला, तो क्या प्रिपेयर्डनेस है आपके हॉस्पिटल की और इन जनरल बाकी हॉस्पिटल्स की, और क्या होना चाहिए? अगर हम मान रहे हैं कि माइल्ड होने वाला है, तो मुझे लगता है कि कोई उसको प्रिपेयर्डनेस को सीरियसली शायद नहीं ले रहा होगा.
देखो, ये तो ना एपिडेमियोलॉजिस्ट का काम है, सुजीत सर का काम है कि ये हमें डराना. और इंडिया में जब तक सर पे नहीं आती, कोई डरता नहीं है, कोई प्रिपरेशन नहीं करता. एंड एवरीबडी फील्स दैट इट इज गोइंग टू बी वेस्ट ऑफ मनी if you try to prepare for extra oxygen, extra something. I think डॉक्टर सुजीत सिंह सर का SMS का हम वेट करेंगे कि अब ये डेंजरस हो रहा है, तब हम तैयारी करेंगे.
तो सुजीत सर तो CGI की तरह चले गए छोड़ के.
नहीं, सर के गुर्गे अभी भी अंदर होंगे. आई थिंक सबकी, वो जो शान पिक्चर में था ना, सबकी खबर रखते हैं सर.
नहीं, आई थिंक धीरेन यू आर राइट. मैं बस दो तीन चीजें ऐड करना चाहूंगा. देखिए, जब पहली वेव के बाद में बहुत बड़े बड़े एक्सपर्ट्स, मैं नाम नहीं लूंगा यहाँ टीवी पे, जिन सब ने कहा था कोविड खत्म हो गया, स्कूल्स खोल दो, सब चीज चालू कर दो. फिर सेकंड डेल्टा वेव के बाद भी डेल्टा वेव आई तो उसने सबको उड़ा दिया. और मेरे को अच्छी तरह याद है, हमारे ऑनरेबल प्राइम मिनिस्टर ने फर्स्ट वेव के बाद दिसंबर में कहा था ऑक्सीजन 120 ऑक्सीजन का प्लांट सैंक्शन किए थे. जब डेल्टा वेव आई तो हमारे कोई प्लांट लगे ही नहीं थे. फिर जब उसको असेसमेंट किया गया प्राइम मिनिस्टर साहब की मीटिंग में, सिर्फ 5 ऑक्सीजन प्लांट वालों ने, मतलब सब कुछ पैसे देने के बाद भी सिर्फ 5 लोगों ने, और इसीलिए हमने हैवॉक देखा डेल्टा वेव के समय, क्योंकि कोई प्रिपेयर्ड था ही नहीं. फिर हमने हर बार प्लांट्स को दोबारा करवाया, सर्विसिंग करवाई, सब कुछ करवाया, लेकिन जरूरत ही नहीं पड़ी. लेकिन
नहीं,
अब ये दो तीन जी
नहीं सर, आपकी, मेरे को ऐसा लगता है सर, इंडिया में हमें अवेकनिंग कॉल्स होनी चाहिए, चाहे वो शेर आए नहीं भी शेर आया.
बिल्कुल सही बात है.
दीज आर द थिंग्स वी शुड बी ऑलवेज रेडी. वी नेवर नो कब मास कैजुअलिटीज आ जाए. हम लोग बेसिकली तैयार ही नहीं होते. जैसे एग्जाम्स की प्रिपरेशन करते हैं ना, 2 दिन एग्जाम रह गया, अब जाके रटाफिकेशन हो रहा है. शायद वही आदत हमारे मेडिकल साइंस में पड़ी हुई है. That includes both, sir, public and private setups. And we always feel that we are never prepared for mass casualties. कभी भी हमारे यहाँ मीन्स उसकी रिहर्सल नहीं होती, राइट? एंड जैसे ये लाइक fire, if some fire happens in some hospital, every hospital try to make shift
Has got a
some.
plan.
या वी डोंट हैव प्लान, इवन प्लान भी जो होता है वहां पे भी हम कुछ अलमीरा रख देते हैं और वो
सही बात।
दरवाजे परमानेंटली बंद हो जाते हैं। जैसे ही फायर वाला आता है उसको पैसे दिए तो काम हो गया। आई मीन टू से ये चीज नहीं बोलनी चाहिए जूम पे, बट वी नो हाउ इंडिया वर्क एंड हाउ वी वर्क एंड वी आर इंडियंस। बट आई टोटली एग्री विद सुजीत सर that even if you prepare little bit, if we sensitize our systems little bit, if we try to overhaul our system with even if these false calls, it's not a bad idea.
नहीं, और हाल क्योंकि मेरे ख्याल में देखिए इतना तो हमको सीखना ही चाहिए। मेरे को धीरेन यू विल एग्री कि हम अपने फ्रेंड तक के लिए बेड नहीं दिलवा पाए। कई बार ऐसी सिचुएशन आई, मतलब इतनी कठिन सिचुएशन थी। तो अगर हम उससे भी नहीं सीखें कि हम प्रिपेयर्ड रहने में क्या बुराई है। अगर हम प्रिपेयर्ड रहेंगे और कुछ नहीं होगा तो दैट इज फाइन विद अस, कोई प्रॉब्लम नहीं है ऐसी।
I
लेकिन
agree.
बेटर टू
I have lost near and dear. I remember जब ऑक्सीजन कम हो गया था तो मेरे पास आई कैन नॉट फॉरगेट ए व्हाट्सएप मैसेज, मामा गंगाराम के बाहर खड़े हैं, कोई अंदर नहीं जाने दे रहा और पापा की सैचुरेशन 50 हो रही है एंड आई कुड नॉट डू एनीथिंग, वी लॉस्ट हिम। आई मीन टू से ऐसे इमोशनल मैसेजेस भरे हुए थे और व्हाट्सएप बंद करना पड़ा था। सो इट वाज वेरी डिप्रेसिंग एंड वेरी बैड टाइम एंड नो वन वांट्स टू रिपीट दैट 2020 सिचुएशन।
प्रिपरेशन, कुछ तो प्रिपरेशन होनी चाहिए, ऑन पेपर तो होने चाहिए कम से कम। वो कैसे
नहीं नहीं
मैनेज
नहीं
करना।
सर, मेरे को लगता है सर
नहीं
ऑक्सीजन
एक्चुअल
सिलेंडर्स
होना चाहिए।
वगैरह, ऑक्सीजन सिलेंडर्स वगैरह तो हमें रेडी, जो बेसिक चीजें हमें रखनी चाहिए सर। एक बार
हाँ
प्रिपरेशन इन जनरल भी हेल्प करती है सर। आई मीन
हाँ
टू से ऐसा नहीं है कि केवल कोविड, कई बार ट्रॉमा का पेशेंट आता है, हमारी टीम्स नहीं रेडी होती हैं।
हाँ
फॉर्चुनेटली अब मीन्स 25-30 ईयर्स हो गए गंगाराम में, तो
हाँ
हमारे पास ऐसी टीम है कि हम सीआरआरटी 1 आवर में शुरू कर सकते हैं,
हाँ हाँ
एक्मो 4 आवर्स में, बट इट टुक अस 25-30 ईयर्स। अब देर आर वेरी ओनली फ्यू सेंटर्स जहाँ पे इस टाइप की प्रिपरेशन होती है, राइट? बट जैसे ही नंबर ऑफ पेशेंट्स आ जाते हैं हमारा सिस्टम हिल जाता है। सो नंबर ऑफ पेशेंट्स के लिए हम लोग probably at national level we are not ready and we were not ready.
इस टाइम तो
मॉक
टेस्टिंग
ड्रिल
किट भी
होनी
हमारे
चाहिए,
पास
मॉक
होगी
ड्रिल।
कि नहीं पता नहीं।
हाँ,
यस,
मॉक ड्रिल होनी चाहिए सर, बिल्कुल होनी चाहिए।
बिल्कुल सही
ओवर
कहा।
टू डॉक्टर केतकर सर।
Sir, population is experiencing post-COVID and long COVID sequelae for past COVID infections. What are the challenges in prevention of these effects and what multidisciplinary approaches are proving most effective and addressing to these chronic conditions?
Ketkar sir, I would like to answer. Actually, in WHO there is a group, a long COVID group, right? I am member of it. And till now it is working and they are still working that, okay, what happened in 2020 and why the symptoms are persisting till now also. So major symptom is chronic fatigue syndromes, depression. What has changed post COVID? Probably our vigilance against and recognition of these diseases like depression. We are now pediatricians who were little bit not very much aware about the depression because our pediatric patients are normally, the playful sort of patients. We were never aware of these things, and especially in adolescent, we found that depression was the major symptom other than chronic fatigue syndrome. Now there is a other group, the other group is that if somebody is suffering from hypertension because of obesity, so they will say, sir, जब से कोविड हुआ है ना तब से ये सब हो गया. So it looks like हर दोष कोविड पे डाल देते हैं, राइट? इट्स ए लैक ऑफ एक्सरसाइज, पुअर फीडिंग, पुअर फूड क्वालिटी और द टाइप ऑफ फूड दे we people ingest. So in general, there was long COVID syndrome, and we don't know whether these are still persisting even after 5 years or not, or actually that COVID just triggered those symptoms and those symptoms appeared in the community. So presently we don't have data in India. We don't have data, and we I feel that at least we should be prepared for some if something happens like severe pneumonia, or you can say walking pneumonia, which used to be a case of your COVID-19, that is classical SARS-CoV-19 Delta strain. So at least we should be prepared for that, and at least we should check our oxygen cylinders and oxygen capability, oxygen providing capability. That much we should be ready for it.
Thank you.
बांगा सर।
मेरा सवाल सभी पैनलिस्ट से है, स्पेशली डॉक्टर सुजीत सिंह से। Dr. Sujit, you have been one of the experts along with Soumya Swaminathan, Renu Sarup, Dr. V.K. Paul, and you all drafted Future Pandemic Preparedness and Emergency Responses Framework for Critical Action for the Government of India. नीति आयोग ने 2024 में ये सब किया था, आपने वहाँ बैठकर। What are the three most critical non-negotiable initiatives which India must make? सिर्फ कोविड के लिए नहीं, फॉर एनी फ्यूचर पेंडेमिक, वो क्या है तीन नॉन निगोशिएबल पैरामीटर्स?
Thank you, Banga sir. And now, because I am not no more part of government, but I like to, because at the time of when I was in government also, then also I used to share my opinion very, very clearly, whether accepted or not accepted, or accepted with riders. That is immaterial for me. But I like to highlight three important points which I think should be important. Number one, policy level and the bureaucratic level, they should value the experts, technocrats' advice, because that has been one of the critical gaps. And once they become, rather they are more arrogant, and they are once they think that they are the right, and then the things go out of hands. That I have seen that we were wasting lot of reagents just for the sake of increasing testing. Everybody was after testing, 10 lakh tests per day. We are sending all the things down the drain. Whereas at that point of time, our strategy or public health strategy was to strengthen the hospital preparedness, strengthen the infection control preparedness, strengthening the testing laboratories. So we did not use our money for strengthening these things. I suggested at one point of time that we should be building one hospital daily. We were having around 200 crore rupees going down every day. So that sort of money should have been utilized in building the best hospitals which we could have done during that particular time. So having said that, there are many areas which need strengthening, but this is one of them. Second most important aspect is having a proper convergence between the private and the government sector. That is one of the important area, because lot of data, lot of cases are going to the private sector. At one point, I must say it with or due apologies to every clinician, that in 4 years of COVID, we had Director AIMS leading the task force, clinical task force, but we did not have a single strategy which could be sent across at each point of time. That what should be the way in which we should be dealing with the patients. We use all XYZ things, right from the what you call remdesivir to the digoxin, DG2 to ivermectin to whatnot. So nobody can justify this sort of combination in any clinical practice, because we did not have proper guidance from our clinical task force. So that sort of guidance, having proper convergence at each level, not only at the national level but a state level also, there has to be a task force between the good clinicians from private sector, government sector coming together and making a protocol which should be given to all clinicians, because we have now IT system going across every year. Third important aspect which I would like to highlight is that we should be like what Dhiren was also mentioning, we should not be complacent. We should be prepared, and even with a good plan, with good prepared hospital preparedness, laboratory preparedness, and community preparedness, if we are ready with the preparedness, even if we don't have a challenging scenario, nothing goes from our hands. But if we are unprepared and if we are caught unprepared, then definitely we may have serious scenarios. So I'll stop here. So I will with due apologies for the harsh words which I have used.
नहीं
Thank
तो
you for giving me.
इसमें एक सवाल जो जूम पर डिस्कस नहीं करेंगे, बस सिर्फ दो शब्दों में, कि इसमें एरोगेंस ज्यादा पॉलिटिशियंस की थी या खुद ब्यूरोक्रेट्स की थी?
भाई हमारे टाइम में तो बहुत पॉलिटिशियन, तो आई मस्ट प्रेज डॉक्टर हर्षवर्धन ओपनली. आई हैव वेरी गुड रिगार्ड फॉर हिम. ही gave me free hand, and he was the one who shielded me from I will not mention that name, but yes, definitely he provided me all the support which I deserved at that point, because one point of time I said that I want to quit, because if my voice is not heard, I am not being allowed to do what am supposed to do for the community at this point of time. There is no point that I should continue at this post. Then
Yes.
Dr. Harshvardhan assured me that he will set the things right, and he did support me in all possible ways. So I have very high regard. Thank you.
सर 2 पॉइंट मैं बोलूंगा यहाँ पे
बोलो.
पहला, अगर रेट्रोस्पेक्टिव स्टडी हुआ है 2024 में रिगार्डिंग हाइड्रोक्सीक्लोरोक्विन, बस सुजीत सर वाज सेइंग दैट जैसे रैम्पेंटली हमने यूज किया है ना, जैसे हम सुनते थे जी अपनी व्हाट्सएप यूनिवर्सिटी में कि ये मेडिसिन काम करेगी, सब लोग देना शुरू कर देते थे. तो हाइड्रोक्सीक्लोरोक्विन लेड टू आई थिंक 20% एक्स्ट्रा डेथ्स, जो शायद कोविड से नहीं होती, और वो मोर्टेलिटी आपके हाइड्रोक्सीक्लोरोक्विन से कहीं लिंक है. वो मल्टी सेंट्रिक स्टडी है, मेरे को पढ़ना है, बट ऐसे ही कहीं से किसी ने मेरे को बताया, मैं एक वेबिनार देख रहा था, तो आई हैवंट सीन दैट स्टडी. Secondly, recently we had the mycoplasma pneumonia. Somehow we found that azithromycin is no more working in mycoplasma. Likely the way we have prescribed azithromycin during COVID could be that mycoplasma is now resistant to it. So I mean to say future में जैसे र्यूमर उठती है किसी मेडिसिन की और हम शुरू हो जाते हैं कि कुछ तो देना ही है, उससे रिफ्रेन करके बेटर टू प्रोटोकॉल.
सर जैसे अभी आपने कहा प्रिपेयर्डनेस, दैट इज द की वर्ड, और इसीलिए ये आज का वेबिनार था, दैट एटलीस्ट वी शुड बी प्रिपेयर्ड मेंटली टू फेस दिस कोविड. हम कुछ सीखें और फिर आगे कुछ कोशिश करें. और एक कहा है ना बड़ा, जैसे हम ऑपरेशन सिंदूर के कॉन्टेक्स्ट में भी देख सकते हैं, द मोर यू स्वेट इन पीस द लेस यू ब्लीड इन वॉर.
परफेक्ट सर, परफेक्ट. मेरे को लगता है सर इस गवर्नमेंट की वजह से हम बचे हैं, नहीं तो अगर हम 2014 से पहले देखें तो हमारी प्रिपेयर्डनेस, स्पेशली जो हमारा एयर डिफेंस था, दैट इज द वीकेस्ट वन ऑफ द मोस्ट वीकेस्ट, एंड अब देखो आप कितना स्ट्रांग था.
हाँ, तो वही कोविड के लिए प्रिपेयर्डनेस तो चाहिए ही.
और मेरे को आज एक्चुअली मेरे बहुत क्लोज फ्रेंड का बर्थडे था, लेकिन आज मेरे को लगा कि आज हमने ये नहीं किया जो जूम है, तो फिर कोई फायदा नहीं है 2 दिन आगे करने का.
थैंक यू. केतकर सर,
From each of your vantage points, what is the single most important take-home message would you like to advise to the medical fraternity regarding role and responsibilities on ongoing vigilance and management of COVID-19? और एक बात मेरे को और याद आ रही है कि it was said the patient was cured of the disease but died of medicine. So that point should be also considered.
To whom this question in director? Shall I come in?
आपके लिए.
I think I'm not confining myself to the COVID. I think in private practice, and every clinician must aim to clinch an etiological diagnosis. Rather than mentioning that this is an acute encephalopathy, acute viral encephalitis, we must, right now we have access to a whole exome sequencing, and we are doing molecular studies also. And here every attempt should be made to clinch specific etiological diagnosis. I think government should also help in it, and every public health hospital, every district hospital should have access to these molecular PCR tests for various viruses. And in 21st century, we should not say it a mystery disease, or they are basically, as Dr. Jekka John used to say, they are the misdiagnosis. Basically, it is our inability to diagnose and cleanse that. Had this COVID-19 occurred in India, we would not have been able to pick up the way the Chinese did. We may have slept over it because we do not have this aptitude to pick an unusual symptoms or unusual disease. I think it should be inculcated in our curriculum also during undergraduate also. For that matter, coming to the vaccines, I think this COVID-19 has got both the bouquets and brickbats as far as the vaccines are concerned. First, the highlighting points should be that we could make COVID vaccines available in the shortest possible time, say around 12 months. It was, and we have for the first time used certain platforms which were not used earlier, like mRNA technology. Few experts got Nobel Prize also for that discovery, and we have used the latest omic, multi-omic capabilities to develop uh, this molecular form of protein, rather than developing vaccine in a different way, like killed vaccine and inactivate live attenuated vaccines. These are empirical ways of developing vaccines. We could now approach a more molecular level. We have defined the pre-fusion, post-fusion, and biological form of antigen vaccines. But at the same time, it has also exposed our vulnerability. What are the limitations of current vaccines? For example, the first is the durability of vaccine-induced protection. It is quite barely visible with these COVID vaccines. We could not have a long-lasting protection against emerging variants. Second was the prevention of transmission. We could not decide whether we need an vaccine for an individual protection or the community protection. During the pandemic, a community protection override the individual protection, and we should have developed the vaccine which prevent prevention rather than giving the individual protection for against severe disease, death, and hospitalization. I think we heard this. Third thing was that the miscommunication, that WHO and other experts, they say that with the advent of COVID vaccines, your transmission will be stopped, you will be protected, and this pandemic will be over in 1 or 2 years. That didn't happen. This caused a lot of bad name to the vaccine science, and the people like RFK Junior, they are now against these vaccines, and we are having a very horrid time right now. So these are the lessons I think we should develop and have to develop better vaccines in the future. And the vaccine hesitancy has risen like anything as far as the COVID vaccine is concerned. After COVID vaccine, entire Western world, people become skeptical of using vaccines, and vaccine word becomes a bad name in India and if, in the world, basically. And if you heard the latest statement by HHS, uh, RFK Jr., he said that by September we should see whether the MMR vaccine causes autism or not. This is basically, what does it mean that he's saying by September I'll declare that MMR vaccine causes autism and you should remove MMR vaccine from your vaccine charts or from the CDC. He may come up with this recommendation. So I think this is these are the few things which we must keep in mind, and the future of vaccine is very bright. We are now developing vaccine not against the infectious disease but against cancer, against certain neurodegenerative disease like Alzheimer's. It was study was published few days back, against the nicotine addiction we are developing. So I think we should keep these things into perspective. We must deal with these limitations of vaccine science, and this is the few lessons we have learned as far as the vaccine part is concerned from the pandemic. Thank you.
Fantastic, fantastic, Vipin bhai. Thank you so much. Now, my last question, probably from the panel to all three of you. First to Dr. Dhiren, and both of you can also answer it. What, in fact, do you think we have learned from COVID? Is it going to stay? Is it going to be severe? or is it going to come again and again? What would be the worst scenario in 2030 and what would be the best scenario in 2030? Dhiren.
One thing is it is going to stay, and if you remember, we have done a lot of web podcast and Zoom, and we always say that it is going to stay, it is not going to go away. But since it has
Going to
limited
stay like
its
a flu,
so
like a common flu.
now what the major change which has happened is that from Delta to Omicron, the main configuration which has changed the COVID is like it is now limited to upper airway. Somehow that the pneumonia causing, that is synechia formation, is lacking, right? So we always assume that it won't again remute to that situation that can kill it host. In general, I think what Dr. Sujit and Vashish sir can comment better than me is that in general, no virus wants to kill its host, right? Nobody wants to kill. Everybody wants to increase its progeny so that more and more it spreads, right? So that's why it has changed from a killer to persistence. So it wants to persist, it wants to irritate, it wants to infect, it wants to kill somebody, not directly by itself. So in general, if you use common sense now, past 3 4 years, we have seen a lot of Omicron. They are, this is mRNA virus and this is going to change. Now you look at all the strain, you start from very basic Omicron and now we are at this one, BF.7 and these. The major change which has happened is the spreadability, transmissibility. Incubation period has become shorter and they are able to spread faster. They are infecting more population at less given time. They're able to evade the immunity, especially B1. T1 might be, might save us from severe disease. But in general, what a science of evolution says that it is going to stay, but less severe. It might mutate, especially like influenza. It entered some in the some dead end host, and it came back to it major shift, antigenic shift happens, and then it lead to like swine flu and sort of thing, and that is unpredictable. No one can predict. But in general, I think next 4 5 years, it is going to show the same pattern which it is showing every year.
Any comment, Vipin bhai, about this?
I think the best scenario would be if it converts into a fifth human coronavirus. It is a milder one. I'm not saying that's going the flu way. Flu way, mind you, has caused severe illness this many years, and flu is definitely is a more severe disease than human cold coronavirus. And the worst scenario would be to the other end of the spectrum would be to develop a new serotype of COVID, and that can lead to a Delta-like illness, which is chances are very remote. I think the best, most probable scenario would be we will continue to have these low-grade transmission with the seasonal uptick in cases. I won't call it as a wave, but a slight uptick in the cases in a seasonal basis, and they may be having the milder illness rather than going the Delta wave or causing the severe lower respiratory tract illness. Until unless they recombine with some other viruses and cause a serotype change or some disease, totally a new virus emerge.
Yeah, sir, before
Great.
Sujit sir says, Bansal sir, one comment on Dr. Vachish sir. Nowadays, sir, there is hardly any patient which is undiagnosed, right? Especially because of not only microbiological advancement, but because of genetic advancement. Previously, I remember there used to be lot of patients we used to call, yaar cerebral palsy hoga, birth asphyxia hoga, right? Now you find that some syndrome, some genetic defect is there. So what has helped us? Right, a patient of upper respiratory tract infection, whosoever is admitted, we are able to make the diagnosis. So users of antibiotic has cut. Second, I would like to, ask ICMR to cut down the cost of all these genetic test, PCR tests. That is going to help us, right? Because presently they are pretty expensive. Thirdly, many patients of cerebral palsy used to move here and there in some hope, some false hope. And we pediatricians never used to convey them directly that nothing is going to happen. We either try to avoid saying to be so straightforward. So patient used to move from here and there, and they used to spend lot of money. Once genetically it has been proved that okay, there is some major genetic defect and this patient is not going to improve other than mild improvement in the brain function. So that helps in the patient at least saving his resources, saving preventing frustration, and because frustration prevails once they move from one clinic to other clinic and they spend money. So these things, the sea change has happened past 10 years, and there's rarely any patient who comes to us without diagnosis, but it definitely incurs lot of money, especially genetic tests. And but that 15-20,000 now genetic test cost has been reduced. So I think we should be liberally using all these tests rather than saying that oh no it's very expensive. But going from one place to other, if one visit to Delhi costs them 10 to 15,000. So let's start using these tests in the Gwalior and small places rather than sending these patients to big centers.
I think the issue is of accessibility of these tests and affordability. This is the problem. Not every hospital is having the Apollo or the Gangaram like setup in small places. People are not having access to these genomic tests, and the issue is the government should invest here in it. You see, one big
Exactly.
political rally is spent. The people spend around crores of rupees, and you can have one good 10 MRIs installed in that district.
Absolutely. That is really pitiable. Sujit, will you like to comment anything or we should invite
No,
questions?
no, I will just sum up into 3-4 sentences. Number one, always whenever new virus comes, we are short of neither we have primers nor we have probes. We have to look at WHO, we have to look at CDC, or we have to look at any German lab or so. Whatever you may say, whenever I have faced H1N1, I have faced SARS-1, I have faced MERS coronavirus, and now this was COVID-19. COVID-19 initially only ICMR was having for 15 days. Then we started having at NCDC. Whole samples from the whole country were piling up in our rooms. So this is the scenario. We need to build up the platforms, and now ICMR has taken an initiative. WHO has classified 15 viral families for which platforms have to be built by the countries. So that is the need of the hour. That is one. Second is from public health perspective, we have taken a big leap. IHIP platform is very vibrant, real time. We can have heat maps. We can have hotspots generated, detected at right time. Problem is, if you don't feed the correct data, you will feed garbage, you will get the garbage. So you need to have the right data fed into the IHIP portal and you'll get very good results. So you can have the direct linkage between the genomic and this. Last point what I would like to highlight is we will not have very severe COVID from this particular coronavirus. Because virus this is the opinion of a senior genomic expert, that virus changes its character just to prevent itself or just to make it more stable in the environment where it is living. If we are trying to kill the virus, we are trying to remove the virus, and virus is trying to protect itself from all these particular the things which we are inventing. So it is changing character. It has changed in 4 or 5 years. It has changed numerous times. So now it has gone into a stage where few waves will be there, few this way, that way. But I per se don't anticipate any delta wave like scenario in this. But having said that, there are many interactions which is going on between the bat virus, bat population and human population. There are many human-animal interface. You have seen Nipah virus in Kerala. 12 other states are also vulnerable to Nipah virus. You can have any outbreak anywhere in our country. So scenarios are there. So whenever we will have the opportunity, virus will jump the species and will enter into the humans. It may not be this virus, it may be some other virus. So I'll stop here. Thank you.
सुजीत जी बस एक बात और बता दीजिए जाते जाते कि अब कॉन्फ्रेंसेस में जाना और शादियों में जाना फॉर द टाइम बीइंग
नहीं,
बंद कर दें
बिल्कुल
जैसे
जाइए।
जाइए।
बिल्कुल जाइए, और टेक्निकल एक्टिविटीज शुड कंटिन्यू, बट लेकिन पेशेंट देखते समय मेरा एक सिंसियर वो रहेगा, अगर आप थोड़ा विजिलेंट रह पाए तो ज्यादा अच्छा है।
ठीक, थैंक यू।
Rahul, I stopped you from asking a question. If you are there, please ask your question, and then we will have comments from the stalwarts present here: Bakul Parekh sir, Dr. Neelam Mohan, Dr. Tuteja sir, Dr. Singarvelu sir. So first, Rahul, are you there?
Probably my mic is not working.
It is working.
It's working. You are audible. Probably
Okay,
you were
okay.
muted.
So my plea is to Dr. Vipin that Corbevax is still available with BE people. Can we use as booster in susceptible population?
I think, as I said earlier, it depends on your objective. It may not be very helpful considering the current scenario and the highly transmissible and evading variants, which are newer ones, which are JN1 variants. If you have I don't find any value of the vaccines based on older or the Wuhan strain, basically. If you have the latest version, they may be helpful, but for particular patients who are comorbid conditions, they have immunocompromised, bedridden, maybe 80, 90-year-old, it's maybe a good idea to give another shot to stack up their cellular immunity, but it may work or may not work. So I don't see any reason to have any recommendation for the older vaccines, basically. They may have another problem of immune imprinting. They may inadvertently make you worse rather than giving some protection against them.
Thank you, Dr.
Bakul
Vipin.
bhai.
Thank you, Bansal sir, for allowing me.
Here.
Thank you.
Bakul bhai.
Hello, can you hear me?
Yes.
Yeah, probably my bandwidth may not be as strong because I'm in a function, but I was listening to the full talk as almost 75% I heard. In between, I had to leave. But whatever I gathered from the talks, what Dr. Sujit Singh said is it stuck to my mind that we are fighting to protect ourselves against COVID, and COVID virus is trying to fight against human beings to kill them. So I suppose it's a fight between the two, and let's see who wins. But at present, as Dr. Vipin said, that we have not to be very panicky about this particular virus, and it will be like any other virus. The symptoms will be like common cold and fever and all those things, but nothing to get panicky at all. Unless until you are comorbid, of course, it is better to take precautions rather than be little risk taking. So you can start wearing mask if required, at least in your consulting rooms and whenever you're going to in a very place where there are lots of people. No? So otherwise, at present, we have to be a little watchful, but not get panicky. So thank you very much, Dr. Bansal, for starting this wonderful series with Gwalior IAP. And I'm sure we'll have many more academic talks and we'll enjoy that academic feast in the coming weeks. I'm sure we'll have many good speakers coming on and talking on some of the practical topics which are going to be useful to the clinicians in their practice. Thank you very much. Thanks for giving me
Thank
this
you, Bakul
opportunity.
bhai. The next in series is EEG in office practice by Anup Verma. And then
Very good.
the common issues in epilepsy by Dr. Brijesh Udani.
Fantastic. It'll be wonderful talk. Yeah. And we don't know how to read EEG. So we keep advising them, but we don't know how to read. We only depend on the
There are
reports. So let's see
many
how it is.
questions. Dr.
Yeah.
Hima Bindu, Madam, Dr. Vineet Saxena, please your
Uh,
quick comments.
Thank you, sir, for inviting for my comment. I heard through all, sir. I was in the hospital when the session was going on. It was very beautiful. It was reminded us 3 years back how much हम कितना कोविड के लिए बात करते थे. तो एकदम all revise हो गया है. And being in the government sector, I want to share that when I was hearing the discussion on preparedness, so we are getting orders from our ऊपर से preparedness के बारे में. We had meetings from all the hospitals and about the कितना ऑक्सीजन प्लांट आपका काम कर रहा है कि नहीं, बेड्स कितने हैं, ये सब गैदर हो रहा है इंफॉर्मेशन. I think the government is getting these things are happening in the government circle to gather information from all the hospitals or the status of the oxygen plants, which they established long back, and what is the preparedness. So, yes, the preparedness things are, the discussion is going on, but I would say there's still a long way to go. We need to be prepared all the time. And I totally endorse with Dr. Surjit Singh saying that the clinicians on the clinical board should be on the top, and the other things they should, policymakers should follow the experts' opinion. So that I totally agree. And I'm sure that this flu-like thing, what we are talking, I hope things are like endemic now. And pediatricians, we need to be still vigilant. Of course, universal precautions have to be taken. Thank you, sir, for giving this opportunity for us to listen to such a wonderful discussions between all the experts. And I wish Gwalior
Thank you.
webinar all the best for the next sessions too.
Thank you. Thank you so much. Dr. Suhas, are you ready with the questions in the Zoom link, or Karunesh in the uh, YouTube link? Are there any questions, or should we proceed further?
So there were only mainly two questions. First was regarding the guidelines for the hospitals. Is there any guideline
That is
for the
already done.
hospitals?
There is no
That is
specific
also.
guideline as of now.
And one was asking me what is the RO factor of new variant? Dr.
Vipin
Vipin
bhai.
sir.
I think they have not calculated. I have gone through the many preprints, but they have not calculated as of now. But they are having this NB181 has got a higher higher ACE2 binding. So transmissibility will be much higher than if you compare with the LF7. And LF7 is one step behind the XBG. So as far as RO is concerned, I think it will be slightly lower than the original Omicron. But right now, the NB181 is the most transmissible lineages around.
Thank you, sir.
Dr. Bansal,
Sir.
the Apollo Hospital has given a guideline. I can share it with you. We have a guideline in the hospital throughout the Apollo Upper India, and I think RO
Great.
factor should be around 6. That's what my wife, who is also dealing with, she's been telling me it's around 6.
Okay. Great.
No, sir, it cannot be
Suhas.
6. It cannot be 6. It will be less than 3 in any case, because R naught is the combination of 3 factors. So if we look at those 3 factors, only transmissibility is high, not mortality, nor severity, nor immunoevasion.
I think it is
Okay.
2.6. It is
Yes,
around 2.6.
somewhere like this only.
Great.
But there is no published data as far as the RO of these
Yes,
two
you are right.
variants is concerned. Yeah.
Yes, sir. It
Tuteja
cannot be.
sir, thanks for joining from United States. A word of blessing and wisdom from you.
सर बहुत अच्छे से ऑर्गेनाइज करा आपने, और देख के अच्छा लग रहा है कि पूरे आईआईपी की डिग्नेटरीज यहाँ पर मौजूद हैं और सबके दर्शन में कर पा रहा हूँ। मुझे यही कहना है सिर्फ कि 2020 में जब कोविड आया, we lost many of our colleagues across India, including pediatricians. Neither government, neither many of the organizations could provide the proper protection to save the doctors. In spite of repeated commitment, repeated asking from many people, from doctors from all over India, we lost so many of doctors. That was a great loss to the country, because how much money we spent to make doctors, and that was exactly required, and all the protection was distributed to the others rather than to the doctors.
Absolutely. Vineet bhai. Vineet bhai, are you there? Singaravelu sir. Dr. Neelam Mohan madam. Anyone want to say, or Sukanta
That's
sir?
very kind of you. Thank you. Just want to compliment the endeavor. Brilliant it was. I had one query which I asked already. Thank you so much.
Thank you.
Had
Thank
it
you.
very nice.
Thank you, sir.
I have
Bansal ji.
Most of the questions are already answered, most all. I think the
Okay. श्वास तुम
only
छुपे क्यों हो?
thanks
श्वास
giving
छुपे
is the
क्यों हो
only.
तुम?
So मैं देखता हूँ.
चलो.
Dr. Dhiren, you're looking so great. Your tie is
Sir,
very good.
sir, thank you, sir.
Sir. Sukanta sir, good evening.
Good evening. And I was listening from, of course, from the late part. It's very useful. And I must congratulate all the experts. The most common clinical question that our colleagues are asking, should we take a booster shot and all that? Those are all discussed and it's nice. Really informative. Thank you.
Great.
And thank you,
Thank you.
Bansal
Thank
ji,
you
for
so much,
arranging
sir.
such a session.
Sir. Anyone want to make any comment, please?
Thank you very much, sir.
Ajit bhai.
Very illustrative and very important. And Tuteja sir very rightly said, for the doctors, we must take all the precautions. We should rather take rest and then good nutritive diet, more of the vitamin C, vitamin D, omega-3 fatty acids, and all antioxidants we should take in plenty. And we should always protect ourselves from the various infections
And
because
we
we
should
people
take
are
good
more
sleep.
prone for that. Thank you, sir. Thank you. Thank you, sir. Thank you very much for
I
inviting
talked
me.
all about that in media. I'm glad you listened very carefully and repeated. Thank you.
Sir. Banga sir for vote of thanks. Or Suhas has gone.
Should we
नहीं नहीं मैं बिल्कुल
should we
नहीं.
consider severely malnourished children as immunocompromised?
Always.
Yes.
Because we have lot of malnourished children.
I
Yes,
think
yes.
if you take the issue of COVID, because you see the most of the complications of severe COVID are because of irregulated immune system, where you have the overproduction of these cytokines. So an immunocompromised or malnourished child may not be able to mount that much of immune responses or produce so much of cytokines to cause the severe COVID-like conditions. So I don't think they are at a much uh, they are more vulnerable than the other kids because
Yeah.
you see the children, they are protected, they have a very robust innate immunity first. Second, there is receptors are very scarce, they do not have that. And third thing is their adaptive immunity is not that hyperactive as in the elderly group. So these are the protective features, and because most of the complications of severe COVID is mainly because of hyper-reactive immune system, adaptive immune system, with a lot of production of cytokines and other things.
Yeah, I agree with Dr. Vipin because what we have seen, like conditions like HLH, these we rarely see in malnourished patients, and mainly immune dysregulated and sometimes immunocompromised patients, especially leukemic. Their nature, their original virus can cause a lot of havoc rather than immune dysregulation. So sometimes severely immunocompromised patients, which are actually T cell deficient or B cell or SCID, they behave in different way. But in general, it is immune dysregulation, and mostly we have seen that patients are obese, poorly controlled comorbidities. They land up in immune dysregulation, and it is something like an HLH sort of thing. What happens, and that is the main killer rather than the original virus.
Sir, in COVID second wave, most of the deaths they have occurred because of this autoimmune problems.
Yes, sir.
And that account is not there with these viruses. So I think the mortality and morbidity has to be less with these.
Yeah, influenza, it is different from influenza. Influenza, you will say mostly it invades the pneumocytes and it causes pneumonia. as compared to Omicron, it doesn't invade the pneumocytes. So the difference, there is a major difference. And so immune dysregulation is caused mainly by other viruses, though influenza, it can lead to both active pneumonia as well as immune dysregulation also.
So coming to the
Influenza vaccine does have some role in this or not?
I don't see any role of
No.
influenza vaccine. No.
No.
You can have some amount of protection from these live vaccines like BCG,
BCG,
OPV,
yes,
but
yes,
none
yes,
of
yes.
MMR, but none of the, you see the systemic reviews and meta-analysis, they have conclusively said that these non-specific effects of live vaccines are protective in COVID.
Yeah.
So the bottom line remains that we do not need a vaccine right now, and we just need a surveillance or an monitoring, nothing to worry, but we should be concerned. That was the dialogue, right?
But
And
we
yes,
should take influenza vaccine otherwise.
yeah,
There is
So
no
I have
reservation on
one
it.
comment, if I may be allowed to give.
yes, please.
Yeah,
Yeah.
I think I would go back to Mrs. Banga's question about malnourished children, and with due apologies, I would disagree with the previous speakers, because if you, I remember reading this and I urge both of you to review it, that though in small children that it is protective because they have immature immunity, but malnourished children, they have blunted and ineffective, and it leads to immunodeficiency, both cell mediated, the mucosal barrier response. And the studies had quoted when the last COVID came, they said that there were higher risk of respiratory complications in those patients with higher incidence of longer hospital stay, etc. And they're more prone because other deficiencies of micronutrients, zinc, etc. And I remember reading this, and because even I used to do a lot of COVID-19 seminars and etc. So there were papers. So I think I would urge you to I mean, it sounds logical when we talk about few things like when Resica Dottrell came, it was such a logical thing that it is going to be effective in ATP and reduce the, volume loss, but it didn't really happen, in vitro or in vivo. So though healthy children are supposed to have milder COVID-19 because of the unique immune profile, but malnourished children are a vulnerable group, and I'm quite sure about it.
Yeah,
And they have higher
normally,
risk
yeah,
of severe
Dr.
outcomes.
Nilam,
Because
Dr.
I
Nilam,
remember talking
uh,
about this in a seminar.
Dr. Nilam, I agree with you to some extent, but practically we have seen like a dengue, like in a dengue,
Kiran, I agree
most of
with you,
time,
but
most of
whenever
time
we
dengue, you
speak, we
will
have to
find that,
speak evidence-based.
yeah, but
So evidence is that.
yeah, in general
You,
means it's not a major problem in malnutrition, but definitely they are high risk for
as
acute
compared to
infection
children.
and pneumonia. But means in general, we whenever we see a obese child and having dengue, we are much more worried than a little bit malnourished. So, but
Absolutely. Dengue to
I
obese
totally,
is
I
very well
I
known to the whole globe,
I
that
agree,
whenever we lose
and
obese
yeah,
dengue.
and we have found that even in leukemics, in the previous waves and Delta wave come, there were no increase in admissions. But some of the leukemics who got infected had severe pneumonia. So I mean to say, still science is not very clear about many things. Of course, all these malnutrition patients, malnourished patients have lot of other problems. So any infection can kill them. May not be typical COVID, no, may not be typical dengue, but of course, the way that dengue, COVID maximally behaves in a killing way in most of the patient is immune dysfunction. So again, I think I agree with you that we should review the science and we'll come back that and definitely we don't see so many malnourished patients as compared to Gwalior people who are residing Gwalior doctors who are taking care of patients in Gwalior. I think they can tell us better. We deal with little bit affluent society. So Dr. Banga, Madam Banga, you can definitely
नहीं
comment
सर,
on this.
ग्वालियर में तो कोविड के
And if
समय
I
में
have
भी
to
और
share
नहीं,
references, where do I share?
कोविड और डेंगू
मैडम
की बात कर रहे हैं मैडम.
कोविड और डेंगू दोनों में मालनरिश चिल्ड्रन में कोई इंसिडेंस ज़्यादा नहीं था. देयर इज, आई मीन ऑल विल एग्री विद मी, ना सीवियरिटी में ना इंसिडेंस में.
मेरे को तो मोटा पेशेंट देखते ही और डेंगू और कोविड हो रहा हो तो
हाँ
आपको डर
बिल्कुल
लग जाता
बिल्कुल,
है.
ओबेसिटी में दे वर क्वाइट सीरियस.
और
COVID में तो
पतला
obesity
दुबला.
was a problem. Management of
Obese
obese
and
problem.
dengue is deadly combination.
Dr. Suhas for vote. Any other question or comments or?
Should there be any mock drill for the preparation?
वो अपन डिसाइड करेंगे मैडम. ग्वालियर में तो अपन कर ही लेंगे एक बार ड्रिल.
Okay, okay.
Suhas, vote of thanks. It's already
Yeah.
11:30.
Well, thank you. Thank you very much first. Thank you very much
Good night.
from to all those who are attending. From my heart of hearts, especially the three stalwarts. हमारे अपने डॉक्टर वशिष्ठ और हमारे अपने धीरेन्द्र और मेरा सबसे सगा सुनील. We are all very happy to share these wonderful words and pearls of wisdom. Dr. Neelam Mohan, yes, the president-elect, Dr. Hemabinder Singh, Dr. Singaravelu sir, Bakul Bhai, or all those from Tuteja sir, Dr. Banga, Madam Banga, Karunesh, Dr. Ketkar, सबसे आखिर में Dr. C.P. Bansal sir. Thank you very much for arranging such a wonderful session. We look forward looking forward for even better sessions in the coming days. Every time, our time management will definitely become better than what it was today. Thank you very much, Sujit sir, and everybody else for bearing with us for our not so very well managed time. But anyway, thank you very much. Thank you, Karnesh, for being there. You are a great asset to the Gwalior Academy PDX. Thank you very much.
Absolutely.
Thank you very much.
Just to add one word,
Yeah.
with this program, हमारे इस प्लेटफॉर्म की बोनी बहुत अच्छी हो गई और धीरेन के नए लैपटॉप की भी बोनी बहुत अच्छी हो गई.
चलिए सर.
So thank you very much,
Thank you.
everyone. We expect
Thank you,
you to join
everyone.
our upcoming
Thank you.
programs.
And Dhiren,
Thank you.
there is a
Hema Bindu
reference
madam
in
और
Dhiren, there is a
सिंगारावेलु
reference
सर
in
दोनों.
मैडम
Nature.
भेज देना, मेरे को भेज
Thank you,
देना.
sir.
To July 21 Nature on data on 1 lakh patients from USA. That data is talking. I'll share it with you because I did a seminar, so I remember. Okay, I'll share it.
Totally agree.
I'll share it. Because nutrition is very dear to me. Thank you.
Thank you.
Thank
Thank
you.
you,
Thank
madam.
you.
Dr.
Thank you,
Neelam Mohan,
Tuteja
madam.
sir.
Thanks
Thank
for
you,
coming.
Suhas sir.
Thank you so much for
Thank you.
sharing the link,
Thank you.
Dr. Saab. Thank you.
Good luck.
Ashok Banga.
Thank you.
Thank you, sir. Thank you,
Thank
C.P.
you.
Bansal sir. Thank you,
Thank you,
everybody.
Thank you.
Singaravelu
Good
sir.
night.
Thank you.
Thank you,
Namaste,
Tuteja sir. Thank
namaste.
you, sir.
Madam, thank you.
Thank you, Bansal
Thank
sir.
you,
Vipin
sir.
bhai,
Namaste.
Dhiren,
Namaste.
the
Sir.
smart person. Thank you so much, everybody.
Thank you.
Good night. Have a wonderful sleep.
Good
Ketkar
night,
sir,
sir. Good
Banga
night,
sir,
sir.
Karunesh.
Good night, sir. Bye bye.
Right, sir.
Thank you.
Good night.
Thank you, sir.
Praji, Jai Ho, Ram Ram.
Ram Ram.
Sir,
Tuteja
namaskar.
sir, कैसे हैं,
Ajib
sir?
bhai, namaste. Deven sir, thank you for joining.
Sujit bhai, namaste.
Thank you,
कैसे
sir.
हैं, sir?